Welcome to Topic 6, Part 2 of Respiratory Disorders. Today we're going to be talking about disorders, starting with disorders of ventilation and diffusion. So first let's start our conversation talking about hypoxemia. And this refers to reduction of the partial pressure of oxygen in the arterial blood. It's defined as a PaO2 of less than 60 millimeters of mercury. Manifestations, some of which are also compensations for hypoxemia, include tachycardia, pallor, and this is due to peripheral vasoconstriction. We're going to shunt blood more to the core, away from the skin. Secondary polycythemia, so in response to the hypoxia, erythropoietin is excreted, and then we get an increase in red blood cells, and hyperventilation. We may have, depending on how bad the hypoxemia is, can have impairment of mental performance and visual acuity. With severe hypoxemia, you can get personality changes, uncoordinated muscle contractions, even stupor and coma. Cyanosis. Cyanosis refers to the bluish coloring of skin and mucous membranes, and this is as a result of deoxygenated hemoglobin. So when all the binding sites on hemoglobin aren't bound with oxygen, we have deoxygenated hemoglobin, which is what we see in the veins, but we can also see this in the arterial blood. Central hypoxemia is evident in the tongues and lips, and this is caused just by an increased amount of deoxygenated hemoglobin in the arterial blood, so we're just not fully saturated. Peripheral hypoxemia, this can be seen in the extremities, and this can be caused by a slowing of blood flow to an area, because then that will result in an increased extraction of oxygen into the tissues from the blood, resulting in deoxygenated hemoglobin. And this can be due to cold exposure, shock, heart failure, where we're not adequately perfusing, shock and heart failure, and peripheral vascular disease, once again, where we're not adequately perfusing. Now, pulmonary vasoconstriction, as we talked about before, helps to match ventilation to perfusion. But if we have widespread hypoxemia throughout the lungs, that's going to cause generalized vasoconstriction, and that generalized vasoconstriction is going to lead to an increase in pulmonary vascular resistance. So then the right heart has to pump against the greater resistance, and that can cause it to eventually fail. Diagnosis of hypoxemia is based on clinical observations, such as cyanosis. We can also look at arterial blood gases, so we can take a sample of blood from an artery, and we can directly measure our PO2, our oxygen saturation to hemoglobin. And we can also use a pulse oximeter. Now this is non-invasive. I can tell you that arterial blood gases are kind of painful. Pulse oximeter, we just put a little pulse ox like on your finger, and that's a non-invasive way to measure arterial oxygen saturation. However, it can't distinguish between oxygen carrying hemoglobin and carbon monoxide carrying hemoglobin. So in smokers, for instance, we could get a higher result than is actually accurate. Treatment for hypoxemia is directed at correcting the cause of hypoxemia, the lung problem that's causing it, and increasing the partial pressure gradient for oxygen diffusion. And this is through the use of supplemental oxygen. So remember when we looked at Fick's law of diffusion, we looked at the factors that affect the rate of diffusion. One of those factors was the partial pressure. If we give oxygen, then we can increase the alveolar partial pressure of oxygen, increase the driving force, and help to increase the rate of diffusion. Okay, so next we're going to look at some of the causes of hypoxemia, and they're listed on the slide here. Decreased oxygen delivery, mismatching of ventilation to perfusion, impaired diffusion, and cardiac shunt. Okay, so the first one is decreased oxygen delivery, and this can be caused either by a decreased oxygen content of inspired air, such as going to high altitude, or I suppose if you were in a closed container and just rebreathing the same air, you would only have so much oxygen. But usually we see this with altitude, so decreased oxygen content with as we go higher in altitude. Another thing that can cause decreased oxygen delivery to the alveoli is hypoventilation. And hypoventilation can be caused by depression of the respiratory system by drugs, so we're just not adequately ventilating. Diseases of the medulla, such as infection and trauma, that can also cause you to hypoventilate. Cervical spinal cord injuries, remember the phrenic nerve comes out of C3 to C5, that region of the spinal cord, and if that has been damaged, that can cause hypoventilation. Or other intercostal nerves also help to aid in respiration. So damage there, inflammation along the spinal cord can lead to hypoventilation. We also have diseases affecting the respiratory muscles, such as muscular dystrophy. Often a cause of death in muscular dystrophy is pneumonia, because you begin to hypoventilate. And they can't adequately clear substances from their lungs. Thoracic cage abnormalities, this could occur with chest injury. Large airway obstruction, you swallow a piece of steak down to your trachea, that would cause hypoventilation. Okay, one thing I really want you to note with hypoventilation, we have hypoxemia that is always accompanied with hypercapnia. Now note that, because you're not going to see that in all the disorders we talk about. So hypoxemia is always accompanied with hypercapnia. So when you hypoventilate, not only do you not get enough oxygen in, but you're not able to get rid of carbon dioxide. So we see both hypoxemia and hypercapnia. Okay. Another thing that can cause hypoxemia is the mismatching of ventilation to perfusion. So we have two extremes. Ventilation without perfusion, this is also called dead space. So over here on the slide, we have, say, a pulmonary embolus that is blocking blood flow to the alveoli here. Okay. So here we have ventilation, but no perfusion. Now remember, we're going to have some pulmonary vasoconstriction to help, we'll have pulmonary vasoconstriction that will help in terms of if our ventilation is poor, but we can also have some bronchoconstriction that will help reduce the amount of air going to that non-perfused area, but it's not complete. So this dead space where we have ventilation without blood flow can contribute to hypoxemia. We can also have what's called a shunt, a physiological shunt. And this is where we have perfusion, so we have blood flow, but without ventilation. So we see here, say, a mucus plug or something is blocking the airflow to the alveoli. So the air can't reach the gas exchange surface. This occurs with atelectasis, which is collapse of the alveoli, obstruction of mucus plugs, which will also eventually lead to atelectasis downstream, edema, airway edema, foreign bodies, or tumors. More common, though, with like COPD, which is a very common lung disorder, we have a mismatch of ventilation to perfusion, where we have low ventilation to perfusion, and that is impaired. With low VQ, we see hypoxemia, and we usually see over time, as it worsens, that PCO2 is usually increased. So with hypoventilation, I said we have hypoxemia with hypercapnia. With low VQ, we have hypoxemia, and then over time we also have hypercapnia. Okay, our next cause of hypoxemia is when we have impaired diffusion. So when we have impaired diffusion, that means our rate diffusion is so slow. It's too slow. We can't fully get enough, fully saturate our oxygen, our hemoglobin with oxygen. So we have very slowed oxygen diffusion across the alveolar capillary membrane. And this can be due to either reduced surface area, where the alveoli come in contact with the pulmonary capillaries, such as with emphysema. Remember, with emphysema we see destruction of alveoli and pulmonary capillaries, so there's going to be just less area for gas diffusion. Or with a thickened respiratory membrane, which we can see in pulmonary fibrosis, where there's scarring and a thickening of that membrane. Pulmonary edema, where we have fluid in that interstitial space that causes a greater distance between the alveoli and the pulmonary capillaries. Now remember, we just said that CO2 diffuses much more quickly than oxygen because it's a lot more soluble than is oxygen. So in a case of a diffusion impairment, we usually see hypoxemia without hypercapnia. Okay, the next one is cardiac shunt. And this is not a lung problem. This is just where the blood flow bypasses the lungs in a right to left cardiac shunt. Most of the cardiac shunts we talked about we were left to right, but we did talk about some instances where we could have a right to left cardiac shunt, and this would completely bypass. There'd be some blood that completely bypasses the lungs. Now in this case, this hypoxemia really stimulates ventilation, and we actually normally see that the PCO2 is normal due to that increased ventilation. So we have hypoxemia with a normal blood CO2. Okay, so now let's talk about hypercapnia. So hypercapnia is when we have increased CO2 level in the arterial blood. And we're going to define that as PCO2 of greater than 50 millimeters of mercury. This is caused by hypoventilation, as we talked about with hypoxemia. We also got hypercapnia. If we have severe VQ mismatch, we also get hypercapnia. So remember, we said with VQ mismatch, we start with hypoxemia, maybe a little hypercapnia, but this increases as our VQ mismatch worsens over time. And then I mentioned, once again, with a diffusion impairment only, we usually do not see hypercapnia, only hypoxemia. So remember that hypercapnia causes respiratory acidosis, and that can lead to an increase in respiration if the lungs are able to compensate. Decreased nerve firing, which can lead to disorientation and coma. Decreased muscle contraction. Vasodilation, which is going to result in warm, flushed skin and headache. With hypercapnia, treatment is going to be directed at decreasing the work of breathing. Okay, maybe improve that ventilation. And improving ventilation to perfusion mismatching. If we have acute hypercapnia and it's causing respiratory acidosis, then mechanical ventilation may become necessary in order to get rid of that CO2 in the blood. Okay, there's our concept checked. Okay, you should take a look at those questions. And then answer this question. Tell whether the following statement is true or false. Ventilation, perfusion mismatch results in hypoxia or hypoxemia. And the answer is true. So in either case, ventilation without perfusion or perfusion without ventilation, oxygen is not picked up by the capillaries and delivered to the tissues. And that results in decreased oxygen at the tissue level or hypoxia. Okay, so now we're going to talk about disorders of lung inflation, including atelectasis and pneumothorax. So atelectasis is where we have non-aeration or collapse of a lung or part of the lung. So the alveoli become airless, and this can lead to collapse, inflammation, and atrophy. And this is going to affect both ventilation and perfusion as a result. We have primary atelectasis, which is of the newborn. This is in a lung that has never been inflated, and this is going to be more common in premature infants. And then we have acquired atelectasis, and there's two types: absorption atelectasis, which is due to obstruction of the airway. We also see this post-operative, and compression atelectasis, due to like a tumor, pleural effusion, increased surface tension, or fibrotic tissue. So let's look at those now. Okay, so absorption atelectasis is going to be shown here. So we have complete obstruction of the airway by like a mucus plug, and then this is going to be followed by absorption of the air away from the downstream alveoli, and that's going to cause collapse of that portion of the lung. So if you think about it here, so these originally this is filled with air, and then we get a block with a mucus plug, and this air can't be replaced or refreshed. Eventually it's just going to diffuse away, and then that's going to cause collapse. So this is a concern in patients post-surgery due to anesthesia, pain medication, and immobility. So this is a reason why they have patients, particularly after like abdominal surgery, blow into like a peak flow meter to cause them to keep their lungs inflated to prevent absorption atelectasis. Compression atelectasis is when the lung is compressed from the outside, and this can be due to like an external mass. It can be due to pleural effusion, that's fluid in the pleural cavity that compresses the lung, or pneumothorax, that's air inside the pleural space compressing on the lung. We can also get compression atelectasis due to increased recoil of the lung due to a loss of surfactant. So if we don't have enough surfactant, that surface tension is too great, and that causes compression. Some of the manifestations of atelectasis: rapid breathing, rapid heart rate, dyspnea, cyanosis, hypoxemia. We're going to see diminished chest expansion on the affected side and absence of the breath sounds on the affected side. Also intercostal retractions. Okay, let's talk about the pleura. So remember, the lungs are lined with a double membrane. The parietal pleura lines the thoracic wall and the top of the diaphragm. The visceral pleura covers the lung. So we have this little space. It's kind of like a glass and cover slip, and it contains a thin layer of serous fluid. And these pleural membranes stick to each other, not like glue, but rather like a glass cover slip in a slide. So when the lungs are stretched out, when the chest goes up and out and the diaphragm goes down, that's going to stretch the lungs open, because they're going to kind of pull that open, okay? Because of that negative pressure in that pleural space will stretch the lungs open. Pleurisy is when we have inflammation of the parietal pleura, and this is usually caused by viral infections or pneumonia. And it results in an abrupt onset of pain on the infected side, which is worse with deep breathing and coughing. And this is going to cause breathing to be shallow and rapid. I experienced this myself one time on the left side. And I was about 20, and I was like, I have chest pain. I'm only 20. What's going on? But as I paid attention, I realized that it was worse with breathing. And I just constantly have this chest pain. So it turned out, I got an x-ray done, and it turned out I had pleurisy, which was just treated with lots of anti-inflammatories. Okay, pleural effusion is where we have an abnormal accumulation of fluid in the pleural cavity. And there can be different types of fluid. We see hydrothorax, where we have serous fluid with congestive heart failure, renal or liver failure, where we just have excess fluid and edema throughout the body, but we can also have it in the pleural cavity. We can have due to pus or infection, like with pneumonia, trauma. We can have lymph fluid in the fetus or neonate due to congenital malformation. We can have blood, hemothorax, due to chest injury, surgery, aortic rupture. These things can lead to compression atelectasis. So if you have excess fluid in that pleural cavity, it's going to compress on the lungs and can lead to atelectasis. Okay, pneumothorax. Pneumothorax is when we have air in the pleural cavity. And this allows that interpleural pressure, which should normally be subatmospheric or negative, less than atmospheric pressure, to equalize with the atmospheric pressure. Or in the case of attention pneumothorax, be even greater. And that results in the collapse of the affected lung, or compression atelectasis. Now remember, each lung has its own separate pleura, so the other lung is not affected initially. There are different types of spontaneous pneumothorax, traumatic pneumothorax, or tension pneumothorax. We're going to take a look at each of these. Okay, so spontaneous pneumothorax. This is where we have air entering the pleural cavity due to a rupture in the visceral pleura. So the visceral pleura is the pleura that covers the outside of the lung. So we can get kind of these little blebs or blisters on the outside of the lung. Okay, so this is where that visceral pleura is just kind of blistered. And if that ruptures, then air leaks out of the airways into that pleural space and can cause a pneumothorax. Now there's two types. There's primary, and this occurs in otherwise healthy individuals, although it seems to be more common in tall, thin people and smokers. And then we have secondary pneumothorax, and this occurs with underlying respiratory disease. So this is usually due to emphysema. So if emphysema, we get more of these blebs because we have kind of destruction of lung tissue on the surface of the lung, and those can rupture. Okay, so that's a spontaneous pneumothorax. It's a rupture in the visceral pleura. A traumatic, also called an open pneumothorax. This is when we get a rupture in the parietal pleura. So in order to rupture the parietal pleura, we have to get a hole essentially through the chest wall. Okay, so this is usually caused by like a rib fracture, dislocated ribs that puncture or penetrate through the visceral pleura, and also can puncture all the way through to the the parietal and the visceral pleura. Anyway, this could also be caused by a stab wound to the chest. This creates a sucking wound where it can kind of make this noise where air can move in with inspiration and out with expiration. Okay, attention pneumothorax. This results when the interpleural pressure ends up exceeding the atmospheric pressure. And this occurs as a result of injury to the chest or respiratory structures that is going to allow air to enter the pleural cavity on inspiration, but there's kind of this, it gets trapped. So there's like the flap that then closes, and then on expiration it gets trapped. So air keeps coming in on inspiration, but on expiration it doesn't get out. So this is even more life-threatening than a traumatic pneumothorax, because the pressure is just increasing and increasing, and this eventually causes a shift in the mediastinum. The whole mediastinum moves over, and we get compression of the unaffected lung, and that can lead, this whole shift can lead to compression of the vena cava, a decreased venous return to the heart, and a decreased cardiac output. Signs and symptoms. All types of pneumothorax are going to have increased labored respiration with dyspnea, tachycardia, pleural pain, and we're going to see asymmetrical chest movements because on the side that's affected, right? We're going to have decreased or absent breath sounds. on the affected side. Asymmetrical, meaning different between each side because one lung is collapsed and one lung is not. Additional signs in spontaneous, so we mainly just see hypoxemia. In traumatic, we can get that sucking noise. We can get some tracheal swing to the opposite side. Decreased blood pressure and moderate hypoxemia. With a tension pneumothorax, which is the worst, we get the tracheal deviation, increased respiratory distress. We can get shock, distended neck veins, cyanosis, and severe hypoxemia. Okay, and then I put together a little table here to help compare and contrast the different types of pneumothorax. So once again, spontaneous is caused to just be idiopathic, tall, thin smokers, or a ruptured emphysema bleb. Traumatic is a puncture wound through the chest wall, usually caused by like a dislocated or fractured rib. Tension pneumothorax, and this can be open due to a puncture through the thorax or closed due to a tear in the lung surface, but either way we get a flap or one-way valve that allows air in with inspiration but traps it on expiration. So with spontaneous, the air entry is from the inside of the lung through a tear in the visceral pleura. In a traumatic, it's from the outside of the body through an opening in the thorax and parietal pleura. And in a tension, it can be either one, through the thorax or a tear in the lung surface. Oops, sorry. Okay, effects. Spontaneous, we get atelectasis, compression atelectasis, and the leak tends to seal as the lung collapses. And this causes one lung to be impaired. In traumatic, we get atelectasis. Air enters with inspiration and leaves with expiration. The unaffected lung becomes a little compressed upon inspiration, but then that air leaves with expiration. And in a tension pneumothorax, once again we have atelectasis. We get air enters with inspiration. It gets trapped with expiration, increasing the pressure in the pleural cavity. And the unaffected lung increasingly gets compressed by this mediastinal shift. Okay, once again, you'll want to review the concept checks. Okay, tell whether the following statement is true or false. An open or traumatic pneumothorax is more life-threatening than a tension pneumothorax. Let's think about that. Okay, the answer is false. Because in an open pneumothorax, inhaled air compresses the affected side's lung, but during exhalation, the lung reinflates somewhat. With a tension pneumothorax, we get a one-way valve that exists. The air enters the affected side during inhalation, but is unable to leave with exhalation. Therefore, we get increased pressure within the thoracic cavity, and unless that's relieved, this can be fatal. All right.